Good afternoon. Welcome to the Comprehensive School Safety Initiative Conference. I'm so glad you're with us here today. Welcome to today's breakout session on addressing student mental health concerns. My name is Barbara Tatum Kelly, and I serve as a social science research analyst at the National Institute of Justice. And my primary interests are in adolescent development and its relationship to victimization and trauma exposure, delinquency prevention, juvenile justice system improvement, mental health, youth gangs, and education. I have some background in clinical psychology and previous experience teaching a self-contained classroom of delightful sixth grade students with emotional disabilities. I'm very interested in hearing more about the approaches that you've studied and addressed, looking at issues of violence, both that outward and inward directed aggression, impulsivity among students with mental and behavioral health concerns. In this session, we will have 4 presentations, and then with the remaining time at the end of the session, we'll address questions raised from the attendees. Please remember to enter your questions into the Q&A section of the screen so that we can view them at the end of the session for answering. Now I'm going to introduce each of our setup presenters. Our first presentation is by Mark Weist and Joni Splett, who will share findings from implementation of the Interconnected Systems Framework, which shows promise for improving student well-being and reducing threats to school safety by offering students both school-based strategies and access to a continuum of interconnected services and support. With that, I turn it over to Mark and Joni. Thank you.
Thank you, Barbara. It's a pleasure to be with you. Good morning or afternoon, depending on where you are in the US. I'll open with a brief story. Carl Sumi, one of our panelists, had prior experience with these grants and told me that if we don't hear in September, we don't get the grant. So I was flying to Connecticut, 5 p.m., September 30th, no word, we didn't get it. My plane landed, we got the word. I called Joni. We were freaking out. So here we are, 5.5 years ago, got the word, and 5.5 years later, here we are. And what a privilege. Thank you so much to NIJ and to the CSSI initiative. It's really, really great to be a part of it. So Joni and I will kind of go back and forth in presenting today, and Colleen Halliday, who's a co-investigator and key person on this project, is not able to be with us, but is also one of the authors. Joni? So for at least about 12 years, we have these 2 major national initiatives, one reflecting positive behavioral intervention and support, which reflects well-done multi-tiered systems of support in schools. Tier 1, promotion prevention, Tier 2, early intervention, Tier 3, more intensive intervention, with a focus on database decision-making, teams, installing, refining evidence-based practices, doing the best possible work, data systems practices in schools to promote students' positive social, emotional, behavioral, and academic functioning. Then we also have this movement around moving the mental health system into schools because youth and families tend to not connect to specialty mental health. And so what we found for about the past 12 years, these 2 initiatives are highly complementary. For example, in PBIS, it's a great system for implementation, but often lacks depth at tiers 2, early intervention, and 3, more intensive intervention. School mental health brings the more comprehensive school mental health, augmenting the work of the school employees, so that, counselors, psychologists, social workers. Now we also have clinicians from the mental health system joining. Adds strength, but typically at tier 3, and the downside to school mental health has been in that it's been a co-located model, so that clinicians come into schools and people don't even really know what they're doing. So the 2 models are complementary, and so for about 12 years, we National Centers for PBIS and for School Mental Health have been working on this complementary framework called the Interconnected Systems Framework for School Mental Health in PBIS. Over to Joni.
So in our project testing the effects of ISF, these are the ways in which ISF enhances those core features, some of that Mark already mentioned, but enhancing the core features of a multi-tiered system, having effective teams that include those community school-based mental health providers, augmenting the mental health resources of the school, so including them in those school teams, expanding database decision-making to go beyond discipline referrals, formalizing the process for selecting and implementing evidence-based practices that are inclusive of that behavioral lens all the way through the full mental health continuum, ensuring that students and children have early access to those practices and interventions through screening, rigorous progress monitoring, and critically important is that ongoing coaching in both systems, in both the educational and the mental health systems, and having a shared district community leadership team that supports that ongoing dual system coaching practice model. I want to say 2014, Mark, 2013? 2013, yeah. This was kind of all first really formalized in a monograph available on PBIS.org, as well as the Center for School Mental Health's website, via a lot of this real kind of operationalizing the conceptualization of what an interconnected systems framework would look like. And then more recently, volume 2 of this was released. It's a monograph as well, or an ebook, about 6 chapters. You can see it's really that kind of what it looks like and what it feels like to implement ISF, all the way from initial considerations, explorations, and adoption to installing, initial implementation, and sustainability. And offering a lot of the kind of operationalizations of what it looks and feels like to implement ISF are really coming from the project we're sharing today. So those examples and the drive coming out of a result of this project.
So again, here's the kind of the formal title of the study and information on when it was awarded, and the disclaimer. And we use the informal name Project About School Safety, and a website, PASS, et cetera, that really helped with the interface with students, families, and schools. If you could go to the next one. So this was a randomized controlled trial. You can see the partners, University of South Carolina, University of Florida, Medical University of South Carolina, and other partners. We had 24 schools total, 12 elementary schools in Charleston, 12 elementary schools in Marion, which is near Gainesville, and 3 conditions. So within each site, 4 schools were randomly assigned. All of them, by the way, were implementing, all 24 were implementing PBIS at some level of fidelity at the start of the study. And then at each of the sites, 4 schools were randomly assigned to just stay with PBIS, to add clinicians from the mental health system, but in the typical co-located fashion, so we call that business as usual, or to the interconnected systems framework. So across the 2 districts, we had 8, 8, and 8 in each of the 3 conditions. And we had 2 years of intervention versus comparison. We were also able to have an opt-out procedure on this, which was phenomenal, really reduced the need for research infrastructure. And this is really no risk study essentially, and it fell in the education exemption systems intervention. So we ended up with academic record data for about 31,000 students, which is phenomenal. And again, we're integrating a more comprehensive approach into the core of PBIS datum systems practices. And we're looking at the effect of the ISF compared to PBIS or PBIS plus school mental health on discipline, perceptions of school safety, student behavioral functioning, and then on a more proximal level, the functioning of teams, students' access to treatment, quality of services, and cost effectiveness.
So Mark's going to talk about some of our outcomes that I think are hot off the presses. And first, kind of describe how we talked about what we implemented, but first describing how we measured fidelity. So we use that via the ISF implementation inventory, which is a tool to support schools and their community partners in installing and implementing the ISF. It can give you a baseline measure across the 3 tiers, and then to monitor progress. So, and has associated forms with it to support action planning. In a separate study, Mark and I have both developed and validated the ISF implementation inventory. So you can see just some of the preliminary validation results there. And it has a newly released version 3 that is available by contacting us. In this study specifically, I think important strength is that most schools in both districts were able to reach the kind of accepted 80% cutoff score in all 3 tiers by the end of the study. So you can see South Carolina, the Charleston district on top, and Florida's district, Marion County, Florida on the bottom, and across all 3 tiers, you see growth and implementation progress and meeting that 80% cutoff. Of course, you do also see when you break it down by schools that we did have, not surprisingly, some schools implementing better than others. So in both sites, when you break it down by schools, we see that 3 of the 4 ISF schools met 80% or above by the end of the study. This is their final fidelity implementation score across all 4 ISF schools in each site. So you see a similar thing happening in Florida, where 3 of the 4 schools met that implementation cutoff. And so I think moving forward, some of our analyses are both that the full sample intent to treat with a smaller subsample of schools that actually implemented with fidelity.
So of course, our final report was due on New Year's Eve, and of course we were working on it on New Year's Eve. It was 1:30, I think, when we finally finished it. These are the authors. It's a complicated study, with probably more than 50 people involved. These are the authors on the report. You go to the next one. And then acknowledgements with, particular thanks to Kathy Gerard, our project officer, and Mary Carlton, our social science analyst, and also the youth and families and numerous advisors from the school mental health world, but also from the PBIS world, along with our coaches who deserve some thanks. So we were excited to see these findings. So in terms of proximal findings in ISF schools, we see school administration more involved with the MTSS team, and again, strengthening that MTSS team is a critical quality indicator. Joni has written extensively about that. We see more school administrators and clinical staff, such as school psychologists, the clinician from the mental health center, actually participating in team meetings. And we saw more discussion of school-wide issues and planning to improve Tier 1 programming in ISF schools. So interestingly, in these schools, we actually had strengthening of the core PBIS elements over time. We saw, better utilization of screening data. So more students proactively identified with needs and referred for Tier 2 and Tier 3 interventions. More Tier 2 and 3 interventions actually provided to students. And for youth of color, we saw a trend of more interventions for them over time. So we know the inequities are not just around youth of color receiving more discipline, but they're also about youth of color also not receiving the needed interventions for them. So we're pleased to see that. We're also very pleased to see these outcome findings. And in ISF schools, we saw reduced in-school suspensions for the overall sample, reduced office discipline referrals for the overall sample, and reduced out-of-school suspensions and ODRs for students of color. So more evidence of the ISF reducing inequities. We also had some trends in terms of student-teacher surveys, more respect conveyed by students in the ISF schools toward other students, greater student engagement, decreased externalizing behavior, and increased perceptions that schools were safe. But these data were more trends at significant levels, but not as strong as the prior findings. And then we did not see any difference in terms of satisfaction with services. exposure to violence and bullying, or teacher reports of aggressive behavior.
More recently, we've leveraged some of these results and tried to extend them into a next step study of thinking about how ISF reduces some of the inequities in the school environment, reduces some of the discipline referral and externalizing behavior over referral and over disproportional representation for African American students. And so Project RISE is funded by the National Institutes of Health. Colleen Halliday, who Mark mentioned, is a co-investigator on our NIJ project. She is the PI of Project RISE, reducing inequities in the school environment. And Project RISE is happening in Florida, where we're taking the ISF framework and enhancing some of the tier 1 practices for reducing unintentional biases and prejudice reduction among teachers and students, and then creating accountability progress monitoring systems for that, using some data disaggregation of discipline data strategies and more diverse teaming practices. So through that, we hypothesize further reduction of disproportionality and improvement of the school climate. So that project is in its second year, and probably like most studies happening now, has some interesting challenges in a COVID riddled environment. So we'll start with new cohort in August and hopefully be able to overcome some of the first cohort's challenges and see how ISF continues to impact that kind of important indicator of equitable outcomes. We've also put a lot of the resources that have emerged from this project and from our study under the mental health, social, emotional well-being tab at PBIS.org and Midwest PBIS. And so if you go to Midwest PBIS, I think you can, and at PBIS.org, you see where you can access like technical assistance briefs, recorded webinars and presentations, all on the ISF, and many of them coming from this project, including one I'm supposed to be editing right now. And there's some websites for further information to learn more about ISF. I think with that too, we give our thanks and appreciation to everyone involved and pass it over.
Thank you.
Thank you very much, Joni and Mark. I really appreciated hearing from you, and I'm sure everyone viewing did as well. Our second presentation is by Carl Sumi, and he's going to discuss Project Secure, which is a multi-tiered approach to strengthen the resilience of students exposed to trauma and considered most vulnerable to disciplinary exclusion and gang involvement. So with that, Carl, I turn it over to you.
Thanks, Barbara, and thank you, Joni and Mark. Mark did tell me he was going to tell a little story about me, and I got a little nervous, and I did threaten him just slightly. So I'm hopefully that story was changed for a really one that didn't really matter that much. But again, my name is Carl Sumi, and I'll be talking about a project, Secure, that was funded also, I believe, in 2016. And my colleague, Michelle Woodbridge, my co-principal investigator. This is a really nice progress of interventions or presentations, I mean, because our Project Secure project is actually a study of several programs that could be implemented within an ISF and PBIS framework. So we have a closer examination of a couple of programs that I'll talk about. If I can get my screen moving here. Okay, so just for the outline of the presentation, I'll just be providing a short overview of Project Secure, talk a little bit about screening elementary students for traumatic stress, and then some preliminary results of the study. So very similar to most other programs or projects in the NIJ Comprehensive School Safety Initiative, the purpose of our program was to really take a look at what would happen if we investigated different interventions at the different tiers. So we wanted to investigate interventions delivered at tier 1, tier 2, and tier 3, and see how they would interact with each other to help support students who are most vulnerable to disciplinary exclusion affected by trauma. We implemented the Project Secure in elementary schools in an urban district. And what we did was we had the schools implement a universal or tier 1 program, social emotional learning program, which was called Second Step. And then we also had the schools implement a targeted intervention for children exposed to trauma, a program called Bounce Back. And we also had a tertiary level program that we investigated that I'll talk about a little bit. But what the goal here was to do a rigorous randomized controlled trial of the implementation of these interventions at their different tiers and see how the results could possibly interact. The majority of the programs, obviously very similar to other comprehensive school safety initiative programs or projects, were implemented by school staff. In this case, the majority of the program was implemented by school social workers, which in this district, we're very lucky they have a dedicated school social worker to each school. But then also at the tertiary or the tier 1 level, teachers were implementing. At the tier 2 level, school social workers were working with students, and also at the tier 3 level as well. So looking at the framed, the tiered approach, as I mentioned, the second step was kind of the basic intervention, the tier 1 used for all students in the elementary schools. People might be familiar with the program, so social emotional learning program. So all students in elementary schools, K through 5, would be receiving Second Step. In Bounce Back was the secondary or tier 2 intervention for children who were exposed to trauma. And at the top of the triangle, students with the most needs, we investigated a program called the City Student Assistance Program, Citywide Student Assistance Program for students with the most level of need. So again, Second Step, a universal prevention program for children in grades K through 5. People might be very familiar with the Second Step social emotional learning program. It's a pretty good evidence base for its effectiveness. Has 22 lessons implemented in the classroom by the teacher. There's also a bully prevention unit that has additional lessons for recognizing and reporting bullying. This was implemented in the teachers' classrooms in the schools that were implementing Second Step, and I'll get to the research design in just a minute. But what's a little bit unique in this project is that the teachers also received support, coaching, and consultation from a district level staff person called a teacher on special assignment. And these teachers on special assignment would support about 5 schools at a time. And they would be doing one-to-one or modeling lessons of Second Step and how to implement and problem solving with teachers if they had any issues, and also presenting the whole Second Step curriculum to the school staff and providing any support that the teachers might need. The secondary or tier 2 level intervention is called Bounce Back. It's an intervention or a program for children exposed to trauma, experiencing significant traumatic stress. This program was implemented by the school social workers, who are licensed social workers, often with an education or a background in delivering evidence-based programs, also programs with a cognitive behavior therapy structure, which similar to Bounce Back. It's a group CBT intervention for young children. It says up to 7 students as 7 participants, but what we learned in this is about 4 to 6 was the perfect number of students. So there's 10 group sessions about once a week, and then there's about 2 to 3 individual sessions with the students as well, and parent groups. And it's very typical approach of cognitive behavior therapy. We're using relaxation, CBT to reduce negative thoughts, exposure, social problem solving. The social workers who implemented also participated in a weekly supervision group and received guidance from other, what they call mentor school social workers at the district level for their implementation. The Bounce Back program, I'm not sure if people are familiar with the Cognitive Behavior Intervention for Trauma in Schools, or CBIS. That was developed for children in the middle school level. It's also been used at high school. The Bounce Back program is developed by the same folks who developed CBIS, and they modified the curriculum to be appropriate for students in elementary schools. Just a little bit more information about Bounce Back. You can go to bouncebackprogram.org. You can register on there for free. They do ask for an email address, but it's really just to track usage. It's not to send you crazy emails down the line. This Bounce Back website is extremely useful for people who are implementing. There's a lot of materials and forms on there. There's video clips that presenters or clinicians or implementers can use. And then what's really great is this online kind of forum for experts and colleagues to get together and problem solve their implementation. And then at the tertiary level, the top of the triangle, the school district that we worked in had a program that has gone through several name changes over the time, but really was for the students who at the highest level of need. And what they were doing was pulling together people across the district and across the city in different types of programs, school health programs, Department of Health, people services within the school district, also probation. They had a lot of people at the table because they recognized that these students had the highest level of need and were often involved in lots of different agencies. And so they would come together once a week to talk about how they could help these students and pool their resources. So our research goals were really to run a randomized controlled trial to evaluate the efficacy of Second Step and Bounce Back. And what the central question was is, if you're implementing an evidence-based Tier 1 program like Second Step, does that provide additional support to Tier 2 types of interventions like Bounce Back? We wanted to see if there were interaction effects between these two interventions. And so we developed a randomized control trial to try to test that out. So the study design, this is where we get a little hard time from our staff because we get really excited about this study design because it's what would be called a 4-arm randomized control trial. At the conclusion, we'll have had 36 elementary schools over the course of 4 years. And each year, the process is the same. Each year, if you just think about 10 schools, half of those schools will be randomized to implement Second Step and half would do what they normally are doing. So 5 schools implementing Second Step and 5 schools doing business as usual. But within each of the schools, either Second Step schools or business as usual schools, we're actually running an intervention of Bounce Back or a randomized controlled trial of Bounce Back. So in every participating school, they're actually screening elementary school students in 4th and 5th grade for exposure to trauma, getting consent, and randomizing students to an immediate treatment group or a waitlist treatment group for students in Bounce Back. And what's happening here, so what you're going to end up getting are some students who are receiving Second Step in their school and also randomized to a Bounce Back condition. Some students receiving Second Step but randomized to a waitlist condition. Some students not receiving Second Step but receiving Bounce Back, and then some students not receiving Second Step and in a waitlist group for Bounce Back. So kind of a pretty exciting design that a lot of researchers, evaluators get a little excited about that. As you can see, I did definitely for sure. Some of the data that we're collecting for Second Step is we're just doing some implementation surveys from teachers about how much time they're implementing, are their lessons delivered, their perceptions of climate and students' social emotional skills. That's just for the implementation of Second Step. The school district that we're working on actually conducts a school culture climate survey every spring. So we have access to those climate surveys in every school that is participating. It's completed by teachers, parents, and students in grade 4 through 5. And it's a typical school climate survey addressing or asking questions about safety, engagement, interpersonal relationships. And then we're also collecting school record data around absences, office discipline, referral, suspensions, and we're trying to obtain also academic state test scores. So those are the outcome evaluation data for the Second Step intervention. For Bounce Back, we're also collecting implementation fidelity data, obviously. We're also collecting some surveys from students. We're only doing the Bounce Back in grades 4 through 5, even though it's been validated for K through 5. We wanted to focus on 4th and 5th grade students only because those are the students also that we would also have the Tier 1 data from. We're collecting the screen for child anxiety related disorders. Yes, it's actually called SCARED. and a social adjustment scale that is completed by the students. And we're also collecting some parent surveys as well. We're collecting these data at baseline, before randomization, and then again at post-test for all students involved in the bounce back. So one of the questions that we get often when we present on Project Secure is, how do you even screen students in elementary school for exposure to trauma? And in a short response is, it's really, really hard. We've done some presentations just on this screening for students in elementary schools for an hour on this process, and I'm going to get it to you guys in 2 slides today. So basically, the traditional screening would be a large screening where you can ask students to complete a checklist or a survey, and then you can follow up with them. Or what's happened most often in elementary schools before is there's a really comprehensive one-on-one interview with the student and the parents. And as you can imagine, that can take a really, really long time. So what we developed through this project and the assistance of the school district is what they started calling the classroom SST screening, classroom student support team screening. And what would happen there is that through this process, they would identify students who had academic or behavioral needs, or who were affected by traumatic stress. And the process was facilitated by a school social worker who would actually just take a 4th grade classroom and work with a teacher to review the data and programs or services or needs of all the students within that teacher's classroom. So they would review the cumulative files, test scores, IEP status, attendance, health needs, discipline referrals, review anything that the teacher or social worker knew about that student. It could also invite other people to these meetings, administrator, other school support staff that know the student. But basically it's reviewing, doing kind of a records review of all the information about that student, about each student within a classroom. And we did that the first year, and we've started to recognize that, as could be expected, students with internalizing behaviors were being left out. Teachers were not identifying, they were over-identifying students with externalizing types of behaviors. So we implemented in the second year a process to help students identify students with internalizing behaviors by including some steps from the systematic screening for behavior disorders, where teachers would nominate 5 students with internalizing behavior problems, 5 students with externalizing behavior problems, and then identify, of those 10 students, any modified screening items from the adverse childhood experiences to indicate any known traumatic experiences. And so what we ended up doing was, if there was at least 1 symptom from the checklist around traumatic stress, at least 1 event from the modified ACEs, and at least 1 academic, attendance, or behavioral concern, and the student would be eligible or considered eligible for the bounce back group. And so through that process, that was the screening process. Again, it was a lot more complicated and involved, but that was the way that we figured that with the classroom SST, the review of the data, identification of student needs, we could determine if students might be eligible or severely enough affected by trauma where they would be a student eligible for the bounce back intervention. This would take about 60 minutes per class. And in previous research, we were starting to find that it was taking 30 to 45 minutes per student when you're doing the individual interviews. And that obviously takes way too long. So that's the intervention. So if you remember, we have second step at the tier 1, bounce back at tier 2, and then the citywide student assistance program at tier 3. Some preliminary results for the screening, cohorts 1, 2, and 3. We just started cohort 4 during COVID. We'll see how that works out. But our overall eligibility rate for students was around 22%, with very wide ranges. And then students with consent was a pretty high level of students consenting to participate in the bounce back intervention. Jumping back to the model again, just to remind you why we're so excited about this model, is because one of the things that we'll be able to do is do a trial of bounce back and see if there are interaction effects of the implementation of second step at the universal or tier 1 level. So we don't have the data for second step yet because we are pulling those data from the district. And last year when we went to pull the data, in March of 2020. I can't remember if anything else was going on at that time, but the districts were really overwhelmed with something happening in the world. So we're still going back to the district now to get some of those data. So the data I'm going to show you now is just from the bounce back trial. This is the screen for child anxiety related emotional disorders. The treatment group, intervention group is on the left. You can see the pre-test and the post-test. The red line across is the line where clinical concern would be above that red line. It looks like there's a little bit of a change here, but that was not significant on this the scared items. But when we, with a main effect of 0.12 p-value, but when we look at the subscales, we did have significant effect for the separation anxiety at the 0.01 level with an effect size of 0.33, which was pretty strong. The interaction with the social emotional or learning second step program was at a 0.29. That was just for the first two cohorts, so we don't really have anything going on there just yet. Social adjustment scale, we didn't have any significant differences either at the full scale or in the subscales, although it was around a 0.08, we still weren't significant there. So just a quick summary of our findings. For the students in the bounce back group did better on the total score and the separation anxiety, and students in the comparison group. They rated themselves basically as exhibiting less overall anxiety and separation anxiety than the peers who received typical services. And these findings are consistent with previous studies of bounce back. We didn't have any significant outcomes of social adjustment scale, and we didn't have any interaction effects just yet, which means it didn't depend if they were receiving second step or in a school that was implementing second step or not. And then the final steps right now, we're in our final cohort year. We'll be pulling in the climate survey data, which we don't have just yet, and additional extant data. And finally, before I conclude, this is a student blog or website where we post preliminary results from a lot of our studies, and actually also information just about evidence-based approaches to supporting students' positive behavior, mental health, well-being. I encourage folks to go to the student behavior blog website, studentbehaviorblog@sri.com or studentbehaviorblog.org to learn any more information. And then there's my email address if folks want to contact me individually, and I will turn it over. And I'm sorry for going about a minute or two over. We'll turn it over to the next presenter.
Thank you so much, Carl. I really appreciated learning about Bounce Back and all the work you've been doing there. Our next presentation is Anna Yaros and James Trudeau, and they're going to discuss the complexity of the findings that they found in the implementation of 3 types of school-based mental health services. So welcome to Anna and Jim.
Thanks so much, Barbara. Yeah, you were right in the intro about complexity. So we're going to try to make it quick and move through everything that we did. I don't have a story about Carl, but I will start with a bit of connection to Mark. We also were expecting to hear about this grant on September 30th, and ended up hearing, really didn't get the information until October 1st. So we thought there was no chance. So we were really excited. And as you can see, have engaged quite a number of folks at RTI International, where Jim and I work. So this project, as I mentioned, was funded in 2015 as part of the Comprehensive School Safety Initiative and began in 2016. So we, if you were following the solicitation at that time, involved categories, and this category was developing knowledge. So it really was designed to be a research project to promote some information and knowledge about what works. And we partnered with Charlotte Mecklenburg Schools, and the partnership really started from the beginning with trying to understand what they needed and wanted for their students and their safety, and then going from there. And certainly what they turned to was mental health and support for mental health. Sorry, just one second. Okay. So I'm just going to briefly go over the link between school-based mental health and school safety. I'm sure we've already heard some about that, and I'm sure you feel well versed in that so far. The study design, which is complex, but not as cool as Carl's, but it's an interesting and complex design. The service level results, where I'll talk a little bit about our implementation, our ultimate staff and survey results in our outcome evaluation, cost effectiveness evaluation, which is an element that we really thought was particularly interesting and important for implications for schools, real schools interested in this type of work, and then mixed methods process evaluation to unpack some of what we found. And then end with discussions and implication. So school-based mental health is defined in our study very similarly to what some folks have already mentioned and discussed. So in Charlotte, there were contract providers who were really embedded in schools and provided services, therapy services, charging Medicaid, private insurance, and then sometimes funded by state and local district funds. But those folks were part of a larger system that was supported by CMS clinicians. So school psychologists, school social workers, and school counselors in North Carolina have a specific license to practice in schools. And each of these three types of providers were also included in our study. And I'll explain how in the next slide. Well, I'll explain how in a few slides, apparently. So just wanted to give you a little bit of background and some of the underlying theory about why we chose to do what we did. We really were trying to make an impact on broad-based school safety, starting with a small number. So really starting at the top of the pyramid with the tier 3 and then some of the tier 2 kids. And so we based our idea on this concept that some of the worst school violence or most disruptive school safety issues are perpetrated by a small number of students. And those students typically would fall into your tier 3 or tier 2 categories in the MTSS or PBIS structure. And many of them may receive special education services, they may receive mental health services, or their needs may not be met. And so we went with the premise that addressing their needs can improve their behavior, but thereby also improve the climate for everyone. And then that's based on some research to that effect. We know that school-based mental health, so embedding therapy inside the school, can significantly improve behavioral outcomes for those students, can also lead to overall school safety and school climate improvement, and can reduce suspensions. We also know academic outcomes, which are incredibly important to, well, to us, but also to our school partners. Those are also empirically related to providing these mental health supports in schools for students. So our study really engaged all of the middle schools to a degree in Charlotte Mecklenburg schools. So we had both a non-experimental and an experimental arm. So I'll start on the right, actually, in our experimental arm. So what we didn't want to do was pull services out of any school that was already receiving school-based mental health services. And so we really benefited from the infrastructure that was already there. And it was there in 25 schools, both 6 through 8 and K through 8 schools. So schools that already had this mental health, school-based mental health program, which was just the embedded therapists in the school, were randomly assigned. And we ended up with 3 treatment groups down there in the bottom on the right, 8 enhanced treatment groups, treatment schools, 8 expanded treatment schools, and 9 treatment as usual schools. And I'll talk about what that means in a second. But what I also wanted to mention is with a clear understanding that we didn't want to randomize or pull away services that were already in place for many of these students or for many of these schools. We wanted to also create as best of a control as we could. So we have a non-experimental arm on the left, which is our comparison arm, whereby we used the 25 schools that did not have school-based mental health and therefore were not as in need or as affected by potential need for mental health services. And we matched them as best we could using propensity scores to our 3 other conditions. So we ended up with 9 of those schools. And again, they're matched based on propensity scores because they are necessarily by design not starting at the same place of mental health need as our experimental arm on the right. So the intervention arms ended up being a menu of services, and many of it's similar to what Mark and to Carl and Joni presented. There are a number of different types of services you find in schools, and it's important to say that these here on the screen were embedded within a much larger school system that also included PBIS in some schools, other potential supports. So we knew that all schools here would have this top level, which was school counselors, school psychologists, and social workers. We also knew that we had this subset, which was the experimental arm, that was already receiving school-based mental health through therapists embedded in the school. What we did were actually use the grant funds to add pro bono slots. So those are slots for students who wouldn't otherwise have services provided because of lack of insurance, undocumented status, a variety of other reasons. So we were able to increase the overall amount of students seen by a therapist from school-based mental health services. Our expanded condition really differentiated from the normal school-based mental health process to include 2 additional supports, which was the student services facilitator and additional school psychologist coverage. So the student services facilitator was an administrative support designed to provide 504 compliance support, testing support, and a variety of other administrative capabilities to the school in an effort to free up that time for counselors. The number one thing that we hear from counselors is they're not counseling. They don't have time to do that kind of thing. They're doing testing, they're doing 504 compliance, they're doing IEPs, and all of that is important work, but we wanted to try to emphasize and try to increase the amount of time that counselors spent on counseling, both at the tier 2 and tier 3 level, and I'll discuss that in a second. And then the last and most intensive treatment arm were the schools randomized to enhanced treatment. And that included all of the things I've just discussed, as well as specific training in evidence-based practice. So this was the idea that if we try to give these schools all the support we can and add training in really intensive evidence-based treatment, how's that going to go? So I'll tell you how it went. So the evidence-based practices that we added in the enhanced group were in tier 2 and 3. Tier 2 received, in other words, students who qualified for tier 2 services received the SPARKS program. SPARKS is a structured psychotherapy group. So it's a group-based therapy really designed for kids who have experienced trauma, but also can be really beneficial in general for emotion regulation. And then for our tier 3 kids who really needed intensive mental health services, when appropriate, they were assigned and received dialectical behavior therapy, which is a pretty intensive but very, very evidence-based practice in outpatient clinical psychotherapy, including getting more so for adolescents. And so it's specifically driven to improve emotion regulation, reduce anger and aggression and behaviors related to that, and then reduce behaviors related to suicide and self-injury. So the DBT practice was really intensive, and it was designed to be administered to kids whose behaviors were really interfering with their place in the classroom. So just quickly, research questions. We wanted to see how our study groups differed. We wanted to look at those levels of school-based mental health. So how did the implementation actually look? We wanted to try to learn about barriers and supports, what worked and what didn't for implementation. As I mentioned before, we had those cost questions. And then questions that we really came to understand was one of the most important ones was, did outcomes function as a, did outcomes change as a function of the service levels or the implementation that were provided? And then lastly, our cost effectiveness analysis. So the data sources that we used, just really quickly, we had a staff survey, we had a student survey, both included many questions about school climate and safety. We did look at discipline data, but that won't be presented. We won't present that today. And then we had a provider survey asking therapists, psychologists, counselors, and social workers about their experiences. As I mentioned, we used a mixed methods process evaluation to really look into the service logs and the interviews with the providers to try to unpack our implementation and how they were providing services. And then our cost evaluation really looked at the startup, which were sort of the costs to get things going and train staff, and then ongoing costs to implement this level of services. So I want to start the results section off by giving you sort of the want moment, which is that service levels did not vary by treatment condition. In other words, when we looked at psychologists and therapists work across treatment conditions, we didn't find the systematic change that we expected. So going back here, we would expect in enhanced treatment and expanded treatment on the right two columns that both psychologist time and therapy time would potentially increase above treatment as usual and certainly above the comparison group. Well, and to be clear, the comparison group does not have therapists. However, we didn't find that systematic change. So on the left, you can see the therapist change over time, and we're particularly interested in the red line, which was the enhanced or most intensive treatment, versus the expanded line, which is the yellow one, and the treatment as usual, which is the green. And you can see that treatment as usual and enhanced increased, expanded, was tracking along and then went down. And similarly, over on the right, the psychologist's time, and this is coverage, this is number of students seen per enrolled student over time. The psychologist's time also didn't increase as we expected. We would have expected that enhanced line, which is the red one, as well as the expanded line, which is the yellow one, to have increased or at least been higher than treatment as usual and comparison than green and blue, but they weren't. So we took that challenge and then tried to unpack that as best we could when looking at our results. So I'm going to let Jim take that from there.
All right, thanks, Anna. Next slide. There you go. Yeah, and I will try to keep this real brief. Obviously, as Anna alluded to, we looked at a lot of outcomes. I'm just going to touch on a few today that I think kind of tell the story fairly concisely. Let me just mention that on these slides, you see time 1, 2, 3, and 4. On the slides Anna just showed, they only reflected time 2, 3, and 4. Time 2, 3, and 4 are data points in the spring at the end of the year. Time 1 is the fall of the first year. Okay, so that's why we just all of a sudden added a data point. As Anna was just talking about, the service levels did not align with the treatment groups as we had expected. And so it's probably not a huge surprise that to a large extent, we were not seeing consistent changes in outcomes between the different treatment groups. We did see some, I mean, we saw some differences between the various SBMH groups and the non-SBMH schools. But just in terms of, that was the quasi-experimental part of the study. But in terms of the experimental part, looking at the randomized schools that had SBMH, there were some differences in some things. The enhanced group did look better, had better trends. But a lot of it, the differences were inconsistent and certainly not at all pervasive or really compelling. And in particular, at time 4, some of the promising trends that we had seen kind of blew up on us. This is just one sort of example outcome that we could look at. This is the staff survey items on, how often do you feel unsafe before school, after school, during school in 3 different locations. We collapsed some of that because there were, the location specific stuff wasn't hugely interesting. But what you're mostly seeing here is not a real clear pattern of group differences on this one outcome. And that was sort of the main story across the board. Next slide, Anna. Thank you. So I'm loath to put up a table like this, in a presentation. It works okay in a report, but bear with me one second and I'll tell you why we're looking at this. Okay, so Anna had talked about, the psychologist, the therapist, the counselor service levels. We looked at it in terms of both the minutes per student in, basically prorated for students in the school, and the percentage of students. We looked where you see concurrent. That means the services in 1 year and the staff survey outcome towards the end of that year. The lagged is services 1 year and the outcomes the following year. Okay, so that's a pretty ambitious thing to look at. But we thought, well, we have the data, and if there are effects there, it would be important to see. What you're seeing in the cells, well, first let me say the outcomes to the left. These are all staff surveys. You'll see that some at the top, the feeling unsafe and the personal experiences, those are about the staff's personal experiences or feelings, whereas the bottom half are more of what they're observing, student behavior, bullying, fighting, disruptive behaviors, things like that. The values that you're seeing in the table are coefficients between the levels of service and the various outcomes. And negative values are good here, okay, because it's more service means less of the various problems that we looked at. And I'll save you from doing the math. You only see a couple positive, i.e. unfavorable associations, and you see quite a few negative, i.e. favorable associations. In fact, of all the possible things that we could have, those combinations that could have resulted, 17 out of 45 of the staff survey analyses showed favorable relationships, more services, better outcomes, which we think is pretty noteworthy, including some in the lagged columns. Okay, so staff, I'm sorry, behavioral health services 1 year improving staff survey outcomes the following school year. All right, and also to note, a lot of the significant findings are in the observations. And we think that's actually important because, those are staff broad observations of what's going on in the school. So anyway, there's a lot to cover. I just wanted to give you, I think that if one slide could convey a large chunk of a study, I think that was it. I think there's a lot of important stuff there. And the next slide, please. I'm just going to run through this cost study real quick. There will be a paper coming out on it. Credit to my colleagues Alan Bernowski and Alex Cowell, who actually led the cost study, but we decided we'd just keep it to the two of us today. Next slide, please. As Anna said, we measured various, the startup costs, the ongoing costs, the startup costs in particular, and just go ahead and jump to the next one. The startup costs in particular, you see for enhanced, very large startup costs. That's all the training that was going on. Those are, basically staff costs of being trained in DBT and Sparks. You see the expanded, not hugely different from the treatment as usual. And again, this is focused on the SBMH schools. Okay, and the next slide, please. And I'm not going to delve into these details, just to say the expanded and the enhanced were both more effective. The effectiveness in the cost effectiveness analysis is focused on student reports of victimization. Okay, so the expanded groups and the enhanced groups were both more effective at reducing victimization, but also more expensive than the treatment as usual group. And down below, this ICER that you see, that's an incremental cost effectiveness ratio. And what this is saying is that expanded was really optimal for improving, reducing victimization at, more cost, but not hugely more. And so in a hypothetical school of 1,000 students, spending $6,800 in the enhanced programming that we were seeing would result in nearly 300 fewer victimization events in that year. So $6,800 for 300 fewer student victimizations. We think that that's probably a good buy. And I'll turn it back over to you. And I apologize for barreling through everything. Obviously, there's a lot to cover. There will be papers coming out, etc. Thank you all.
Thanks, Jim. And in the interest of time, I will move very quickly through these slides as well. Just wanted to say we did do some qualitative analysis of implementation frequency and how often folks were implementing them. So high implementation versus low, and high implementation really meant, psychologists were seeing 15% or more of the students in a building, therapists about 5% or more. Kids were getting, and this is per student in the entire building. So again, we use these metrics knowing that not every kid saw the psychologist, but sort of averaged it across the entire enrollment. About 50 minutes or more for the psychologist, 30 minutes or more for the therapists were really our high implementers. And our high implementers tended to show quite a bit of supports. So you can see that included collaboration. It also included an increase in capacity. I will just point out here, regularly expressed to us was the high burden of DBT and Sparks. And we are also working on a paper specifically on that. And it really may potentially explain some of our results and why enhanced may have a little bit less bang for the buck. But these clinicians or providers were really taxed by learning this and doing consultation groups and all sorts of really intensive work that may not have had the bang for the buck as just regular treatment as usual by those staff. There's a few quotes. One that I just like to point out is this comment about the inverted triangle. We expect the triangle to have 15% or small number at the top. But actually, in many of these schools, many of those students are having education interfering behaviors and mental illness. So I think that's a common theme, unfortunately, across the country. So just moving quickly to our discussion, I know in general, we saw that levels of student services were impactful in school safety, and that enhanced and expanded were effective, but also were costly. And that many of the barriers and the need for students sometimes make it challenging to implement, especially intensive evidence-based practices. So we obviously had limitations, and I'll also just make a last-minute plea for more research. I'll mention we have a presentation tomorrow at 2:30 on whole school interventions, specifically for equity. But certainly more increased research in this tier 2, tier 3 space is needed. So thank you to all of our collaborators, especially Charlotte Mecklenburg, and then our NIJ folks who were incredibly helpful as well.
Thank you so much, Anna and Jim. I know it's not easy to condense such complicated findings into meaningful feedback to the audience, but I think you did a great job. We're now moving on to the fourth presentation with Jill Bohnenkamp and Cindy Schaeffer, who are going to address the impact of the emotional and behavioral crisis response and prevention intervention on school safety. Take it away, Jill and Cindy.
Thank you so much. Hi, everyone. Great to be with you today, and great to hear these different models of promoting school safety via emotional and behavioral health supports. We are thrilled to be able to share this model that we tested via randomized controlled trial with Baltimore County Public Schools. I'm Jill Bohnenkamp, and I'm joined by my colleague and co-investigator, Cindy Schaeffer. So we'll dive right in. So this project was funded in 2014 by the Comprehensive School Safety Initiative, and we are thrilled to be able to share final findings and not preliminary findings, and especially to share more details about some hot off the press findings that have just been published in Prevention Science, and we'll be going through those today. So our goal of our presentation is to describe this multi-component preventive intervention to address emotional and behavioral health crises, and to understand results from the 2-year randomized controlled trial. So to give you an overview, this trial looked at the impact of the emotional and behavioral health crisis response and prevention intervention, a mouthful, ERBH-CRP for short, specifically on school safety outcomes. In the 2014 funding mechanism, this was awarded directly to the school systems with university research partners. So this was awarded to Baltimore County Public Schools, and our National Center for Mental Health team served as the research and evaluation.
Jill, excuse me, I'm so sorry to cut in. We're having a little trouble hearing you. I don't know if you can get a little closer to your microphone or speak louder, please.
If I turn it up and talk louder. Thanks.
Yes, that's better already. Thank you.
Okay, great. Okay, perfect. Thank you. Thanks for that call out. And we were thrilled to partner with April Lewis, who is the Executive Director of the Department of School Safety. So to give you some context, Baltimore County Public Schools is one of the largest school districts in the nation, 123 schools and programs, and it covers a huge geographic region that spans urban, suburban, and rural areas. And really the focus of this program, and when we were approached to partner with the school system, was this concern over the growing number of student emotional and behavioral health crises that couldn't be quickly diffused, modified, or resolved, and were presenting a significant risk to school safety. So these were coming into the school safety office frequently, and they felt like they did not have a streamlined process for how to best resolve them, and they were a significant risk to school safety. And so the school system and our team worked on developing this comprehensive training, organization, and support protocol for school and community stakeholders. I think a common theme that we're seeing is this importance of a multi-tiered comprehensive approach. And this approach was aiming to increase broad stakeholder competence in responding to and preventing student emotional and behavioral health crises, looking at combining evidence-based, culturally competent, and school-informed strategies, and importantly, to be able to address emotional and behavioral health crises across the continuum, and not just addressing them when they were at the crisis level. So specifically, we looked at these research questions. So if we implement this comprehensive model, which I'll go into much more detail about what was in that model, will we see an impact on school safety outcomes? And in secondary ways, will we see an impact on mental health service utilization outcomes, and also the quality? We also looked at stakeholder knowledge and preparedness, and conducted a cost-benefit analysis. For the purpose of this presentation, we'll primarily be presenting on the school safety outcomes. But just like folks talked about, we have forthcoming manuscripts on these other outcomes as well. So our study design was looking at outcomes at the school level, and so we—
Jill, I'm so sorry. Your volume dropped off again.
Oh gosh. Okay,
I don't know why it's varying.
Thanks for letting me know. Can you hear me better now, Cindy?
No.
Okay. Let's see here. Let's see if I get closer. And is that better? Okay, great. So Cindy, I wonder if you might want to talk about our study design, and I'll grab my ear pods and see if that helps.
Sure. Yes. So our study did, can everyone hear me okay? Okay, I'll assume yes. So our study was not district-wide. It was with a select group of schools that were most struggling in their safety outcomes selected by the school system. The the selection of schools was allocated to feeder patterns in the district because we were working with elementary, middle, and high school levels. We needed to, and there would be crossover of kids during the study period. We needed for schools to be within the same feeder pattern. So we had 40 schools total, and they were randomly assigned based on feeder patterns. So the randomization was not at the school level, it was at the feeder level. The baseline year was 2014, 2015. And the intervention was started and kind of, I guess, was at full throttle more in year 2. And Jill, are you able to talk about the components of the intervention? Not quite yet.
If you all can hear me better now.
It might be a little better, but.
Okay, I'll continue to stay close to the mic and perhaps stop my video and see if that helps with sound. Okay, so we'll move on to talk more specifically about the intervention component. So as I mentioned, this is a comprehensive model, and so we worked with the school district to think about what supports they already had in place and how we could bolster some of those services, and also make sure that we were thinking about universal prevention, early identification, thinking about assessment and service linkage, and unique to this project and what they really felt like they needed additional supports on were crisis response and post-crisis relapse prevention. Cindy, are you able to hear me better now?
Yes, it's quite a bit better. Thank you.
Okay, all right, great. And so I'll dive in and share more about the interventions at each level of this model. So at Universal Prevention, we had the Safe School Ambassadors Program, which is a student-centered intervention to identify and train students to intervene, prevent, and stop bullying in the schools. And schools were also implementing PBIS, and so we had some additional supports to help to bolster this. It was really important that we had a student component here, and we were really glad that the school system was thinking about having the Safe School Ambassador Program to really think about multiple stakeholders, and very importantly, student stakeholders. In terms of early identification, the state was already implementing the Cognito program, which is a 30 to 60 minute online suicide prevention and mental health intervention training. This was not being utilized though in many schools across the state. And so via this grant, we were able to increase folks who were receiving this training, and across intervention schools, 80% of all school staff in the building were trained in that model. Schools also had varying degrees of mental health services and supports, and so part of this intervention was to assess the current strengths and gaps for each school, and to make sure that we were streamlining programs and resources across school mental health services and EBH crisis supports. And so, as I mentioned, this crisis response was a key area where the school district felt like they needed additional supports, and across the country that we hear school districts talking about the need for this. And so a main part of this model was the implementation of a crisis facilitator, who basically was a mental health staff, a mobile mental health staff that was specifically for the school district. And each feeder pattern within the intervention condition was assigned a crisis facilitator who the schools could call when there was a student in crisis. And that person would come and work directly with the school teams, allowing school staff to be able to not have to take large chunks of their day, managing students in crisis, but really be able to have some of that happen. And then to have that be more streamlined in terms of follow-up, which I'll talk about in just a moment as well. Also, both the crisis facilitators as well as school mental health staff, so school psychologists and school counselors, were trained in the life-based crisis intervention model to help to improve crisis de-escalation. And I'll show just a couple of tools that came out of this. The Emotional Behavioral Incident Report. This was a way for schools to be able to track and better understand what type of EBH crises were happening in a more standardized way. And we have a manuscript in preparation that hopefully will be coming out soon with that. And then, so another critical piece was after a student crisis happens, they did not have a system in place, and we hear from many school districts across the country that there's not a system in place to be able to follow up with that student and ensure that we have relapse prevention. And so this process helps the crisis facilitator to plan post-crisis response. And here's just an example of what that looks like. Also, manuscript in preparation, sharing more about this tool. Okay, and so as I mentioned, there were a number of outcomes that we looked at, but specifically today we'll be talking about these school-wide primary outcomes of suspensions, office referrals, juvenile justice referrals, and threat and risk assessments. And I'll turn it over to Cindy to share those school-wide safety and discipline results.
Hi, thank you. So we have more outcomes that we will be examining, but as Jill pointed out, we're focusing today on our primary outcomes, which were around safety and discipline, school level indicators. And we are excited to report that these results were just accepted and pretty rapidly published online in Prevention Science. So if you want to drill down more deeply on the details, you can access that manuscript. I think Jim mentioned earlier the hesitancy to show, you know, a bear of a table like this. So apologies again, but this does sort of summarize most of our outcomes here. So our analyses, again, these were school system level indicators, so their own data systems, and we used 3 time point latent growth models to look at change in some key outcomes over time from the baseline year across the 2 intervention years. So all of these outcomes that you see on the left column, suspensions, office referrals, juvenile justice referrals, and bullying reports, like reported to the offices of each of the schools, all of those are count data, which are highly non-normal. So we used appropriate linkage functions for those growth models, including Poisson and negative binomials, whichever linkage fit those non-normal data the best. And what you'll see for the columns are these models provide an intercept, estimate for intercept, but then of more interest would be the slope, which is the average change over time for all schools. And of interest to our study, the slope on condition columns, which shows the effect of the intervention package on those outcomes by school. So we would hope to see in that S on condition column, lots of negative values, all this bad stuff going down, and then for that rate of change to be significant. And so Jill has highlighted here the significant findings. Again, this is with an N of 40. So this is, you know, in some ways a small sample size for these analyses, but nevertheless, we looked at everything at the overall level of 20 versus 20 schools, essentially, and then drilling down on some subgroup differences, also with the effect of condition on these subgroups. So as you can see, we did not have an overall effect of the intervention on school suspensions over time. At the average level, those were kind of staying steady during the period of the study. However, for the multiracial students in our sample and also among secondary schools, we did see significant declines in the number of suspensions for those 2 key subgroups. Similarly, for office referrals, there was general declines overall across the years, but in the secondary schools who received the intervention package, that decline was significantly more. So we had an excellent effect on discipline referrals and suspensions for the secondary schools only. The juvenile justice analyses were just for secondary schools. Again, intervention advantageous there, that although those were increasing over time, on average, the rate of increase was less for our intervention schools. So they were feeling the need to, they were not keeping pace with the overall trend to refer more kids to juvenile justice. And then same for bullying. Bullying was trending upwards at the overall level, but less so for intervention schools overall, and the effect is driven largely by the primary schools there. Okay, next slide, Jill. So we felt good that we had some overall effects on some key indicators, but we wanted to understand whether the intervention was impactful upon disproportionality itself. So first we had to define disproportionality, which this is a standard ratio formula in the field. So it's basically the ratio of the subgroup of interest on the outcome over the majority group, the same ratio for the majority group. And if the two ratios are the same, you would expect the overall ratio to be a value of 1, just equal portions of both groups having the negative outcome. When I don't think we have the actual disproportionality ratios. We didn't make a slide for that, but we did examine disproportionality for 3 subgroups. And what these results, these are not the disproportionality ratios, these are the regression models using that ratio as the dependent variable, looking at whether condition, the intervention condition affected disproportionality, and the answer is it did not. So taken together with our overall findings, the intervention was very successful in bringing suspensions and office referrals down for secondary schools, bullying reports down for primary schools, but it did not have an effect on disproportionality itself. So even though all groups were benefiting from the intervention, disproportionality still persisted across time for those groups. Okay, and then we also examined threat assessments, which is another school level indicator of when a student makes a statement or exhibits a behavior that indicates risk of harm to self or others. So self-injury behavior, a statement of suicidal behavior, or something, an aggressive threat towards another student or teacher. The formal threat assessment process is done by school emotional behavioral health staff. And if we're going to be reducing disciplinary approaches, we might expect these to go up. And in fact, that's what we found, at least at the secondary school level. So looking at that slope column, overall and for secondary schools, generally schools were doing fewer of those, or they were staying pretty stable over time since those aren't significant. But in our intervention schools, those were actually, at secondary intervention schools, those were going up. So we were showing some increased, we think hopefully appropriate threat assessments happening in lieu of the disciplinary stuff. And then the follow-ups to those threat assessments also increased for overall and for both primary and secondary schools. So we feel that the intervention was sort of socializing or conditioning school staff to shift from a view of a disciplinary response there to more of a therapeutic view, and really, as indicated by the follow-up effects, not just assessing those, but continuing on with some intervention for those kinds of concerns at a higher rate than our comparison schools did.
All right, so to summarize, I think as many folks have talked about, this idea of implementing a multi-component model across many schools is we could spend a whole hour talking about that, or perhaps a whole conference talking about that. And so, we were glad to see that happening. we also saw this uniform crisis response and post-crisis relapse prevention happening, which was really something that the school system was lacking and felt like they needed, and saw this as a key piece here. And as Cindy went through, we saw that resulting in lower incidence of discipline response, especially in our secondary schools where we were seeing higher rates of that to begin with. We think in our primary schools, and we've seen that, those rates were lower to begin with. And so really where that was key, we saw those lower incidents. And this was supported by seeing, a different indicator, but also a school safety indicator, that we saw bullying reports being lower in primary schools. And we see that as, perhaps one of those school safety indicators indicating that this whole model is supporting that move towards school safety. And unfortunately, we did not see moves towards discipline processes being more proportionate. And while each of the interventions in this model were selected to be culturally responsive, we really see that there's this kind of increased need to make sure that these interventions are anti-racist, and that we're thinking, very specifically about targeting that to see the changes in disproportionality. And we were, really thrilled to see this more use of proactive threat assessment and follow-up procedures coupled with that less disciplined response. That this multi-tiered model, when you're training multiple stakeholders, students, teachers, school mental health staff, and having additional crisis supports, that we're really seeing that shift towards school safety. And encourage you, if you want to get into more of the details, to check out our publication and Prevention Science. The citation is there. Thank you so much.
I really want to thank Jill and Cindy, and kind of invite everyone that presented back onto their virtual screens. We haven't received any questions entered into the Q&A box, and we have all of about 5 minutes left, maybe 4 minutes. So I had a question for the group. Basically, all of you were funded under CSSI, but this work has such a broad range of applications above and beyond just what happens in terms of school discipline and school safety, to issues around what Nicole Hockley described as mental wellness, that then permeates the life course of a kid in terms of avoiding suicidality, having better involvement in terms of academics, in terms of avoiding bullying experiences, and also juvenile justice system involvement being lessened. And so as you look at this work, there's so many things that when you help a kid be on a positive pathway and overcome traumatization and reach more mental wellness, then they can permeate so much of their lives. So I know we have all of about 3 minutes, but if anybody'd like to jump in on that topic, go for it.
I'm probably the oldest here, so I'll take a shot. I think your comment, Barbara, reflects the need to work across initiatives, across federal agencies, across systems, so that this is should be a shared agenda and all relevant to all the federal agencies, obviously NIJ, SAMHSA, NIH, the Institute of Education Sciences, CDC, but also reflecting a shared agenda in communities: education, mental health, child welfare, justice, disabilities, family and youth leadership. And these studies really provide a suggestion of a platform for us to build the work through these collaborative cross-system initiatives that are driven by the stakeholders. I'll hand it off.
Thank you very much, Bart. Go on. Go ahead.
Has a comment. Maybe he doesn't.
Well, I think he
does.
Maybe he doesn't. I think you summed that up really nicely. One of the things that I work on is a Federal Interagency Coordinating Council on youth programs, and this might be a topic that we'd like to present to them in the future, so that more agencies could be actively engaged in the constructs you've developed and the measurement techniques, as well as your exciting research approach. And with that, I think I want to thank Tina, who has been our tech support for this entire meeting and has kept us so ably on task. And everyone, you did such a lovely job of presenting. Thank you so much for joining this conversation today. And to our attendees, and of course, to all of our research participants, very, very welcome. So thank you.
Thank you.
Thank you all.
Thank you.